You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 23rd, 2019. This week, TAVR, neuromodulation for heart failure, SGLT2 inhibition for heart failure, and myocardial viability to predict success after coronary bypass surgery. First up is that last Friday, after I recorded This Week in Cardiology, the news came that FDA expanded the indication for several transcatheter heart valves to include patients with severe aortic valve stenosis who were at low surgical risk. Now, the approval was expected after the PARTNER 3 and Evolute trials returned positive results in low-risk patients with AS. FDA approval now ushers in a new era in the treatment of patients with AS. This is big. The trials were definitely favorable, and I don't want to sound too skeptical, but like most cardiovascular trials, their follow-up was short, and aortic valve replacement is certainly a long-term therapy. So, as part of the approval, FDA now is requiring manufacturers to continue to follow up patients enrolled in these randomized studies for 10 years. This will further monitor the valve safety and effectiveness. And this will include, importantly, the long-term valve durability. Participation in the STS registry will also be mandatory, and this will be a positive thing as we'll get more data from the real world. My friends, this is a major transition in the way of treating patients with aortic stenosis, and it comes with great responsibility. The TAVR trialists have really done their job well. Now, will cardiology use this technology wisely? Will we resist the urge to do TAVR in low-volume hospitals? Will we resist the urge to do TAVR in patients without symptoms? I worry about indication creep. And finally, will cardiologists embrace decision tools to help patients make this important decision of surgical versus transaortic valve replacement? Second topic today is baroreflex activation therapy. Now, systolic left ventricular dysfunction induces sympathetic stimulation, which, in the long run, can be maladaptive. Modulating the autonomic response to systolic heart failure may be a fruitful way to approach these patients. There are three general types of autonomic modulation. These include spinal cord stimulation, direct vagal stimulation, and carotid baroreflex activation therapy, abbreviated BAT. This week, the FDA approved a BAT device called the Barostim Neo. It's a pacemaker-looking device implanted in the upper chest, and it includes a lead that courses subcutaneously to stimulate baroreceptors in the carotid bulb. Now, baroreceptor stimulations cause afferent signals to the brain, which then inhibit sympathetic activity, enhances parasympathetic activity, and these efferent signals then have the effect of decreasing heart rate, vasodilation, and decreasing renin secretion. FDA approval was based on preliminary findings from an RCT called BEAT-HF, and it's a special and complex trial that I'll spend some time on. It was designed in close collaboration with FDA regulators. BEAT heart failure trial enrolled patients with heart failure with reduced ejection fraction, EF less than 35, who had class 3 symptoms despite guideline-directed medical therapy and were not candidates for CRT. Now, the trial takes advantage of the expedited access pathway called EAP, which, after the passage of the 21st Century Cures Act, is now called the Breakthrough Devices Program. BEAT heart failure was designed to obtain two types of FDA approvals. This first one, the expedited phase, measured quality of life, 6-minute walk test, and BNP levels with the device. Now, the authors of the trial presented this data at HRS meeting in May, and all of the data trended positive for the device, though I cannot see that this data has been published in manuscript form. Now, the second part of the BEAT heart failure trial is the extended phase, and it will measure harder outcomes. Now, this gets in the weeds a bit, but the statistics plan used a frequentist approach to analyze the expedited phase and the final analysis of the extended phase, but a Bayesian approach was created for the posterior probability of a positive trend in the hard outcomes data. Bayesian approaches also helped guide the adaptive design of this trial for sample size decisions. Now, I highlight these issues because the title of the methods paper was, quote, "First granted example of a novel FDA trial design under expedited access pathway for pre-market approval." Well, I'm learning more about Bayesian design, so I'm a bit of a novice, but the reason this is notable is that it moves us away from reliance on a P-wave threshold, in which 0.04 means the device makes it and 0.06 means it may not. Rather, with Bayesian probability, one gets an estimate of the likelihood of benefit with different assumptions ranging from skeptical to optimistic priors. Now, FDA approval here marks only the first step for this new and novel device. I don't think we'll start seeing it used until CMS weighs in on a coverage decision. And finally, keep in mind that the positive data on symptomatic endpoints should not convince anyone this device is beneficial. The BEAT heart failure trial is an unblinded trial comparing a person who got an operation and a device to a person who did not have an operation. Remember, if CRT has a big placebo effect, and it does, one can only imagine the strength of the placebo effect that this surgically implanted device might have, and simultaneously consider the nocebo effect or subtraction anxiety of being randomized to the group with no device. Before we start implanting this device, which I'm sure will be expensive, I would strongly encourage waiting for the heart failure and mortality data. Now, the third topic today is also a potentially new medical treatment of heart failure. But before I tell you about the news on dapagliflozin and heart failure with reduced ejection fraction, let's just do a very brief review. Sodium glucose cotransporter 2 proteins transport glucose in the proximal tubules of the kidneys. They are an ideal target for the treatment of diabetes because 90% of filtered glucose reabsorption occurs via these proteins. The normal renal threshold for reabsorption of glucose corresponds to a serum glucose of about 180. In patients with type 2 diabetes, this threshold can increase and the expression of SGLT2 can be upregulated, and that causes a maladaptive response that worsens hyperglycemia. So selective inhibition of SGLT2 inhibitors can reduce this threshold to as low as 40 to 120 milligrams per deciliter. Now, currently, there are 3 SGLT2 selective inhibitors approved by FDA. These include canagliflozin, dapagliflozin, and empagliflozin. These drugs have 2 important metabolic effects. 1, weight loss, and 2, lower blood pressure, which is believed to be due to a diuretic effect. In patients with type 2 diabetes and established heart disease, the SGLT2 inhibitor empagliflozin has been shown to reduce cardiovascular death. Now, the most important adverse effects of this class of drugs are genital infections, increased risks of DKA, and amputations. Now to the news on dapagliflozin. AstraZeneca, the maker of the drug, announced in a press release this month that the DAPA-HF trial, an RCT in patients with heart failure and reduced ejection fraction, quote, met its primary endpoint with statistically significant and clinically meaningful reduction in CV death or worsening heart failure. The final results will be presented at ESC later this month. DAPA-HF is the first heart failure outcomes trial with an SGLT2 inhibition with and without diabetes. The trial had about 4,700 patients with heart failure. The EF entry criteria was less than 40%, high BNP, but a GFR greater than 30. patients with type 1 diabetes were excluded. And I got this from the methods paper that's in the European Journal of Heart Failure. Of these 4,700 patients, the mean age was 66, 23% women, and 42% of the enrolled patients had known diabetes. Of the remainder, about 2/3 of the patients had prediabetes and 33% had normal hemoglobin A1C. The primary endpoint was time to first occurrence of CV death or heart failure hospitalization or urgent heart failure visit. Now, the company also said in the press release that safety outcomes were, quote, consistent with the well-established safety profile of the medicine. I went over the background first because I wondered why this drug might help patients with heart failure. Here, I point you to the dapagliflozin CV outcomes trial that was published in New England Journal of Medicine in January of this year. While the drug did not reduce the rate of major adverse cardiac events, it did result in a statistically significant absolute risk reduction of 2.3% in heart failure hospitalizations. And this reduction in heart failure hospitalizations was noted soon after randomization, which suggested a mechanism of action different from those patients usually considered for conventional glucose-lowering therapies. Now, of course, we need to see the actual data to assess the effect size and safety data. And remember, too, this would be all on top of guideline-directed medical therapy. And gosh, this is getting a lot of medication for patients with heart failure to take. The next topic today concerns myocardial viability. Now, I will never forget this case. A man who I followed because he had a pacemaker for bradycardia presented with severe angina, heart failure symptoms, who had a high-grade subtotal left LAD occlusion. He had some Q waves anteriorly, and he had anterior wall akinesis. He didn't have an acute MI, but rather this gradual decline over many months. And when I saw his cath films, I was relieved because I figured bypass surgery would help him. But no, the interventional cardiologist said the anterior wall was dead. He needed a viability study. Now, I was doubtful but deferred due to my status here at my hospital as an electrician. Now, so the nuclear scan, the viability scan, came back no viability. Bypassing the LAD won't help. 2 times dead is dead, went the logic here. And I'm like, really? We're going to make a life-altering decision on a nuclear scan. So I called my surgeon. I said, can you see him? But the short story here was that patient was operated on, and he did beautifully. And this all happened many years ago, and every year that I see this patient, I think about that his life almost turned on a nuclear scan. And I remember the story so well because it confirms my bias, and my bias is that clinical care should never ever turn on one test. Well, this week, the New England Journal of Medicine published yet another paper from the STITCH trial. Now, the STITCH study consisted of 2 trials, one a surgical revascularization component and a surgical ventricular reconstruction component. The trial randomized 1,200 patients between the years 2002 to 2007, and these patients had ischemic cardiomyopathy, EF less than 35, coronary disease that could be bypassed, and they either got guideline-directed medical therapy or surgery. The primary endpoint was overall mortality. CV death and CV hospitalizations were the secondary endpoints. In the analysis of data from the surgical revascularization component of the STITCH study, at a median follow-up of 56 months, this was published in 2011, there was no significant difference between surgery and the medical group in the rate of death from any cause. But then, in the 10-year extension trial called the STITCHES trial, the CABG group had a statistically significant 7.2% absolute risk reduction in overall death. This most recent analysis, published Wednesday, was a sub-study of patients in the STITCH trial who had had a myocardial viability study. Now, the authors sought to answer the question of whether or not an assessment of myocardial viability could identify patients who would benefit from surgery over medical therapy. And it turns out that 600 of the 1,200 patients in STITCH had a viability assessment either with PET or dobutamine echo. Now, the reason only half the study had viability tests was that the original protocol mandated it, but then that was abandoned due to slow enrollment. Now, crucially, the group that had their viability assessed had the same death and CV death rate as those that did not, so they looked similar. And among the 601 patients of this sub-study, 81%, 487, were considered to have a myocardial viability as defined in the protocol, and the remaining 114 patients, 19%, were classified as not having viability. So right off the bat, you see that these are unbalanced. But the incidence of death did not differ significantly between patients with viable myocardium and those without viable myocardium. And this non-difference was there even after adjustment for other prognostic variables. The authors also found no significant interaction between the presence or absence of viability in either the primary or the secondary endpoint. Now, an even smaller subset of the 600 patients who had viability also had serial assessments of ejection fractions, a second EF measured at 4 months, and here the authors found no significant correlation between the change in ejection fraction and the amount of viable myocardium. So my comments here are first the caveats. Of course, this is a post hoc comparison of uneven groups. One might even argue that in a sub-study with small numbers, it's possible there was an interaction that was not detected. You can make the type 2 argument, however, in many neutral trials. Now, I agree with the author's conclusion. These RCT level observations do not support the concept that assessment of viability determines the likelihood of long-term benefit from surgical revascularization in patients with ischemic cardiomyopathy. Does it exclude that viability might be helpful? Does this data preclude using viability always? Well, probably not. But the practice of using viability to adjudicate who gets bypass surgery should certainly stop. Now remember, if proponents of a practice say it is beneficial when the average effect in a trial is negative, the onus is on the proponents to show which patients this therapy helps. 2 brief announcements before I close. Next week, the Heart.org Medscape Cardiology heads to Paris for the ESC meeting. Look for preview columns on the meeting early in the week next week. Second announcement, 2 studies on AF ablation came out recently, and these stimulated me to write a column that deals with 2 trends in AF ablation that worry me. Look also for that next week as well. That's it for This Week in Cardiology. As always, I am grateful that you listened, and remember, if you like this podcast, please tell a friend, consider subscribing and giving us a review. That way other people can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.